Hi, and welcome to Evermore's In the Know. We get to have monthly conversations with bereavement researchers and experts. And today, I'm very excited to have you tuning in, as well as having an opportunity to talk to Dr. Ted Rynearson, who I absolutely adore, and we'll introduce Ted in just a moment. For those of you who are new to our In the Know conversations, go ahead and submit your questions in the chat. We do our best to prioritize audience questions. We'll get the conversation rolling. We've already actually gotten a number of questions from audience members today, so we'll get to those in just a few minutes. Sometimes on rare occasions, we don't get to everyone's question, but we certainly follow up on email and try to get all of your questions answered. If you'd like to stay in tune for these conversations, you can follow our newsletter. We're going to place a link in the chat to our newsletter. We have a really fantastic PhD joining us next month who's going to talk about the neuroscience of love and loss and how the brain adjusts to yearning. And we hope you'll join us for that. But any longer, Ted Rynearson is someone who is very dear to me. He certainly, if there was something to happen in my own family, I would hope that I could call Ted or Ted could make time for me. He is someone that I respect tremendously in this field, and I've learned so much from him in the years of meeting with families and meeting with practitioners and clinicians. He is an expert and really paved the field, at least in my own mind, as the grandfather for me of violent death, loss, and how families and clinicians and people like me can support other families. He's done a whole bunch in his life, and I won't belabor his bio too much here. You can read all about Ted in the materials where you signed up. But he is coming to us from Seattle, Washington, and he is semi-retired and has devoted really a life and career to violent death and dying. And he has been a national and international teacher and lecturer on these set of topics. And so with that, I just want to take an opportunity to welcome Ted, and thank you so much for joining us today.
Well, thank you. It's an honor to be here. And Joelle, what a lovely introduction. I was touched, particularly that the sort of trusting relationship that we've developed, that you would even consider involving me and your loved ones in terms of helping them.
Oh, absolutely, Ted. You're on my short
that
list.
is a rare compliment. I appreciate it.
Oh, stop. That should not be a rare compliment. But let's get started. So I know a little bit about you, but I would like to understand why medicine, and sort of back us up just first to why, you even started a career in medicine to begin with. How did that come about?
Well, some would say that I didn't have any choice. My father joined the staff of the Mayo Clinic as an endocrinologist in 1926. So I was raised in Rochester, Minnesota. I had 3 older siblings, and my brother became a psychiatrist. He's 7 years older than I. One of my older sisters was a social worker, and the other was a recreational therapist. So we all got involved in supporting people emotionally. By the time I finished my medical school training, I was very interested in going into psychiatry, but then spent 2 years at St. Elizabeth's Hospital rather than going to Vietnam. St. Elizabeth's Hospital in Washington, D.C., which then had 7,000 inpatients. And I was a general medical officer in charge of 700 patients for their medical sorts of difficulties. So by the time I finished those 2 years, I got very interested in sort of the neurobiology of chronic mental disorders, and decided I wanted to go into neurology and psychiatry and get boarded in both. I went back to the Mayo Clinic for my training. Started off in neurology, but after 6 months, I decided I was much more drawn to people and their stories than I was in the role of being a diagnostician. So I switched into psychiatry and finished up at the Mayo Clinic, and then went down to Texas for 6 months, worked with my brother, and then my first wife, Julie, and I decided to go to New Zealand, where we spent a year, and I almost didn't come back. This was in the early 70s, a wonderful place. But Seattle drew me back to the United States, and particularly the kind of work that I wanted to do, which was pivoted around group therapy and more intensive psychodynamic therapy. I knew a lot about medications, and I had a lot of experience with taking care of people with major psychiatric disorders. But in the 90s, I could see what was happening in psychiatry. I was the head of a psychiatric section that had 30 people in it. And when I retired, that was in 1998 when I took an early retirement. And now, in terms of that department, there's one person left. And I anticipated that this was coming, that psychiatry and mental health was not going to be supported in major medical institutions. They wanted psychiatrists to do consultations and write prescriptions, and I wanted to do more than that. So that's why that's sort of been my psychiatric career. That since then I've had a para career, I think, working in this much more intensively in this whole area of complicated grief. So that's. Go ahead.
No, I was going to say, I'm very glad you came back from New Zealand, and I've had the pleasure of knowing you. How have you taken this issue and sort of made it your own? I mean, again, I've learned so much from you, and I think to your point about prescriptions and how you attend to bereavement generally, but in that violent death is unique, and we'll talk about that in just a moment. But you've certainly had personal experiences too that have brought you into the fold of this community even more.
And I need to talk about that, particularly at the beginning of every talk that I give. I talk about my own personal experience with violent death, because I think it's a very important part of my paradigm. I think when we begin to talk dynamically about psychiatry and adjustments to trauma, it becomes very self-referential. There isn't an objective sort of diagnostic measure, obviously, of any of the psychiatric disorders, really. We're still based on description of signs and symptoms and duration of symptoms, but it's not that way with grief. There is no pill for grief. I'm glad to hear that you're going to have someone talk next month about attachment and neurobiology of that, which I think is really interesting material, but it has absolutely no clinical relevance. There isn't any medication that we can use at this point for grief, and that's been elegantly studied in the last 10 years with prospective randomly assigned groups of patients with very significant grief, and pills don't work. What works is much more effectively is a restorative sort of intervention for people that are stuck in their grief. We're left with this image of a person that they really can't live without. And it's a very small percentage of people that go through a grief reaction that are disabled or sort of absolutely bound to this experience. Probably less than 10%. I think there are a couple of studies that suggest around 7% of people present with what is now called prolonged grief, which unfortunately, to some extent, has been declared a psychiatric disorder. I don't think it's a disorder as much as it is a rite of passage in terms of the identity change that people have to go through when they've lost someone who is a very important part of their own self-identity. And that's, as I see it, that's what needs to be focused on in a restorative, reframing sort of way. Now, this all began, my focus on violent death, because in 1974, my first wife died. Her name is Julie, and Julie and I moved to Seattle in 1972 after we got back from New Zealand. I busied myself setting up the shared practice between the University of Washington and a large private medical center here in Seattle. She was a Montessori teacher. We had 2 children, preschool children. Decided to have a 3rd child. She became very depressed during her pregnancy and was being seen obviously by another psychiatrist and therapist. And she had responded to that, was doing fairly well. But within days of the birth of Wendy, who is our infant daughter, Julie went through a really serious postpartum depression. And a month later, Wendy, our baby, died suddenly from an intravascular hemorrhage. So where before I've been an empathic clinician in this whole area of grief, at that point I became very much a participant observer. And I recognized that I was going through something that, in terms of the phenomenon of the loss and the way it had occurred, that wasn't captured in any of the models that I've been taught or read about, really. And I'm often asked at this point, as I begin talking about this, how'd you get through it? What'd you do? And of course, what's important is to try and protect yourself from doing too much, which I think is a real temptation, a real reflex after something like this, because you feel so helpless, because the dying is so violent, and particularly if it and so sudden, you haven't had an opportunity to prepare. And I think my major source of resilience for me and a lot of people that have to go through a significant death, I found resilience by being resilient for my two little kids, who were then 5 and 3. So I insisted that I find some sort of support for them. I was very worried about them. And never really got any help myself. I'm not sure that I needed any early on. I don't think that therapy is something that should be seriously considered, other than support and sort of first aid as people are going through this in the initial weeks and months. But to recognize that within 6 or 12 months after any kind of death, natural death or violent death, that people go through a lot of spontaneous improvement. And it's important to wait for that and not get involved in a lot of uncovering therapy early on. I was left with 2 separable distress responses that are central in my model, and 2 narrative responses. And I think what we go through after the death of someone that we're emotionally attached to is that we process it through stories of our relationship with the person. When I was a real doctor and on a surgical service, when I was in medical school and my internship, I got very interested, and this was before I'd gone through this violent death. I got very interested in people that were going through an amputation, because you had to prepare them the night before that when they woke up and whatever limb had been or digit had been amputated, that it would still register. They would wake up and whatever was gone was still there. There was a presence within absence, and it's called phantom limb sensation. It never goes away. It diminishes with time. But we know that there's a certain area of the brain, and some of this has been worked out, that continues to be activated despite the limb not being there. I think roughly analogous is what goes on after the death of an important part of ourself, not just our body.
Absolutely, and I would say, yeah, the neuroscience is emerging now, so that we've had some neuroscientists on previously, and it's been, I think, very validating for a lot of people that it's not just that you're sad. There is something physiologically unfolding, neurologically and biologically.
It's a natural sort of response. And I think that is reassuring for people to know they're going through something that has a neurologic basis. If only we could do something about that. If only we could alter that somehow. Well, we do. I think restorative retelling, the model that we've developed, I think has, and I haven't been able to validate this, but other studies have. They show changes in this sort of orchestration of what's going on neurologically in terms of all of these centers does change with therapy, with certain therapies. So even though it's as a neurologic basis, it's something that can be approached, I think, dynamically and naturally, and allowing people to process what's happened in a different way. Now, I was left with two separable narratives. And this is what's different about violent death. You not only have the narrative of attachment, which is attractive and stabilizing and meaningful, and you want to connect with that narrative because it's so comforting, versus the narrative of the way the person died suddenly. When you weren't there, you had no part in that narrative. That's a story that didn't belong to you if it was a suicide or accident or a homicidal dying. So it registers as a surreal sort of flashback. And that's what I was left with the initial weeks, maybe a month or two after her dying, was that I would awake with recurring nightmares of the act of her dying and flashbacks during the day that would intrude. And in part, I think it's because there was no role for me in that story. If she had died from a leukemia or something that we could have been prepared for, I could have been a part of that whole dying narrative. It would have changed its space, its time, and its quality, so that I could have walked away from that dying narrative knowing I had played a constructive role, or as constructive as I could, in terms of saying goodbye and preparing my kids.
And just for clarity, Ted, so you mentioned Wendy's death, but I don't think you mentioned Julie's. So when you're talking about the two narratives,
no. That's what I'm talking about. I think that Wendy's death was sort of secondary for me. Primary was losing Julie, which had been a nine years of relationship. And of course, I was also devastated by the baby's death. But in terms of the day-to-day ongoing connection with my kids and reestablishing the family, and it was her suicide that I was focused on, the way that she had killed herself, and that she was all alone. She was all alone when she died. It still tears me up. And it does, I think, for most people that have gone through this kind of an experience, they should be there when the person dies, if they died naturally. So I think that the fixation that sometimes occurs after violent dying is related more to the narrative of the dying than it is to the narrative of the living. And it's the people that are coming in 6 to 12 months after the dying that can't calm themselves from these intrusive images and nightmares and panic attacks. Those are the people, I think, that are at highest risk, particularly if they've lost a baby or a child. Mothers that have lost children are particularly vulnerable after any kind of a death, but particularly after violent death, because I think mothers have socioculturally great demands on them when it comes to nurturance and attachment, and that the safety and proximity of their baby, regardless of the age, was there from the time of pregnancy. In most women, they were developing a pre-verbal attachment, really, which continued the first year without a lot of words. And so that the attachment, I think, registers at a different level than it with women than it does with fathers when it comes to babies.
Sure. And I want to make sure we get to a couple of the questions that we had submitted, and we don't usually get a number of questions submitted in advance, but for you we did today, and so I want to ask you a couple of those so we make sure we have time for that. Robin writes that dear friends of hers lost their wonderful 33-year-old daughter to a random stabbing almost 2 years ago. She's at a loss on how to be supportive other than donations, and they are so devastated, and so many of their friends want to help. The parents insist on referring to their daughter's murder rather than her death, and it makes Robin and others feel very uncomfortable. It's even on their daughter's gravestone, and it's a word that Robin says that she can never get used to. And so I guess the question, is it's a word that makes you feel uncomfortable. It's yet what the parents are insisting on. What is your advice for Robin, and sort of what is your reflection on her comment?
Oh, wow, that's a lot. And how was Robin related to the person that died?
Just a friend.
Just a friend. And what is the word that triggers?
Murder.
Murder. Right.
The parents insist on saying that their daughter was murdered.
Even on the gravestone.
Correct.
Well, my goodness, it bothers her friends. Imagine what her parents are probably going through as well. But I think this is an illustration of what I was beginning to develop for you, was the fixation that can go on with the dying imagery that can eclipse the living memory of the person early on. And what's different, I think, about my trauma model from Edna Fuller's trauma model of extinction, which is, of course, to be exposed to the trauma over and over and over again, so that you get some sort of mastery by being able to stabilize yourself in the presence of this image just by re-exposing yourself to it. I think that works with an assault or a rape or something that involves somebody that you don't know necessarily. But this is very different, I think, when there's been a murder of a family member or a close friend, because you've lost an important part of yourself as this person has died, so that needs to be reestablished. In other words, the living memory of the person needs to begin counterbalancing this horrific image of the dying, to bring them into some sort of a balance, so that the idea isn't to extinguish the murderous imagery. The idea is to master it to allow it to slowly catch up with you. And the restorative retelling intervention, what we do quite purposefully is to work on the living imagery before we begin working on the dying imagery. Focusing on the living imagery brings stability and meaning, and knowing the person's name, knowing a picture of the person. That's what I ask the first session when I'm evaluating someone. What's this person's name? Let me see their face. I mean, this is what we go through neurodevelopmentally in terms of beginning to register an image, which we did, when we were really tiny, probably about a year, and began developing stranger anxiety in terms of the mother's face that would calm us down. But to bring that into the intervention. So if this young woman was grieving about the death of Nancy, or if the parents were, and came in to see me, that's how I would start. Do you have a picture of Nancy? I need to know more about her and your relationship with her. If Nancy were here, how would she help you with this? If we enlisted Nancy's support, what would she feel that you needed with an intervention with us? To ally ourselves with this living image of the person before we even began dealing with the traumatic image. I don't want to know about the traumatic image right away when people come in. I also want to know, I'm not at all religious, but I want to know about their belief systems about death and dying. That can be enormously reassuring, particularly after a violent death, that the person is no longer trapped in this traumatic narrative, that their spirit is distant and at peace, and sometimes promises reunion, so that there's a meaningful metaphor that's going on that's important to address early on in terms of spirituality and belief systems. And how has this changed you would be what I would begin to focus on next, because there are really only two stages with grief. There's who you were before, and there's who you are now. And that's very different, I think, than the Kubler-Ross kind of stages where you go through something epigenetic, and that just doesn't happen. So you could see already what I begin to build into the model just on the basis of what I've been through personally.
Is that what you recommend? Oh, I'm sorry, Ted. Is that what you recommend sort of supporters do?
Exactly.
Yeah.
Exactly. I think anytime that you know that someone you're being drawn into a situation of violent death, it's important to get to know the person when they were alive before you even begin talking about the dying and the death. But Joelle, you've done this for years. How do you approach people? And you're not a clinician, I know that. What I'm getting at is that I think we're all, hopefully, have natural resources of being able to communicate with people at a natural sort of level, and to recognize that there's some sort of ordering about all of it. You don't get into things too quickly. You listen, don't you?
Right. Yeah. You someone actually said to me today, in fact, you step in and you are there. You listen, and you're a supportive force. And to your point, and I think maybe to answer to Robin's question, is just really, focusing on the person who was so wonderful, who was lost. And I mean, the injustice that those parents carry, that their daughter was taken from them. And, continuing to be there and to listen. I think sometimes that's, even as a bereaved parent myself, I think that's one of the greatest gifts is someone who doesn't run away, and who's just able to bear witness to the story.
Well, absolutely. And I mean, I think that's what's so touching about your work, Joelle, is that you've established something performative, something outside of yourself to bring meaning and justice and hopefully a national sort of effort to deal with. That's something very positive and constructive about what's happened. And I do the same thing. I recognize with my efforts to train and to write is to make something meaningful out of something that challenges that. Particularly after most suicides, particularly with young people, at least in my circumstance, I wasn't going to find any meaning in that narrative.
Can I want to ask you another question. Actually, I have two. One from Mandy, who is curious if you have any advice on how to approach a group of people affected by the death of a suicide for a person under the age of 18 years old, and what are the first steps as a grief supporter you would recommend? I think we talked about this a little bit, but any nuance for a person under the age of 18 and anything specific as it relates to suicide?
I'll tell you who knows a lot about this is one of my favorite theoreticians and clinicians of death with children is Alison Salome, who's at the University of South Florida, and she spent her career working with kids after a violent death, suicides, homicides. The first 8 or 10 years of her career, she would actually go out with the police and the chaplains and begin working with the families right away. And it takes longer term work. And a lot of it is school-based. Bob Pinus and the Childhood Traumatic Stress Network has done wonderful work with Kathleen Nader was involved in that, developing programs, school-based programs where you actually go into the classroom and work with kids. Sometimes I think it's very effective to do that at a group level rather than an individual level because of what could go on in group in terms of the kids taking care of one another. But I've been primarily an adult psychiatrist. I have not dealt extensively with people who are 18 or younger.
Well, I will share that Alison will be joining us later this year.
Oh, great.
Sloan. So yeah, so we'll put certainly that question aside. So I have another question from Heather, and it is in regards to bereavement in group settings, bereavement support in group settings, that she was not able to find support groups that were specific to tragic loss. And her question is, do you know if they exist? Many people do not want to seek therapy and don't fit well in standard group support. And she's just wondering how best to direct people for group support in tragic loss.
Well, I have some ideas about that. We started, I developed, with the help of my staff, a time-limited group intervention that we've developed here in Seattle called restorative retelling. It's a 10-session intervention. Each session lasts for 2 hours. It has an agenda. And I think that that's comforting for people that are going through a violent death, is to know that they are joining a group that has a beginning, a middle, and an end. Because often what goes on with an open group, a drop-in group, is that some people are there forever. And dropping in means that you're also dropping into people or group members that are at different stages of being a group and different stages of their grief. So I would look for a time-limited group intervention that deals specifically with violent death. Because I think there, as I've begun to outline for you, there are specific dimensions of violent dying that don't get addressed adequately, I don't think, in a group after natural dying. usually therapists aren't used to dealing with a lot of these ideas and models.
Ted, are you comfortable? I mean, after this session, happy to share the restorative retelling manual with the people who are interested in attendance, and also with this, with Heather herself. I think the manual, at least for me, I thought it's brilliant, and wonder if you would be open to us sharing that with a few people.
Of course. Anything that I've published, I have no proprietary sort of interest in it. I'm not making any money from this. You can download the PDF for nothing, and it's about 70 pages, I think, that manual, which has also been translated into Spanish, into Hebrew, and to Arabic, because the University of Washington sent me over to the Middle East for 5 consecutive years. So I did a lot of work in Gaza and Israel and Jordan and Syria when you could still get in. That information is all there in different languages. And my email address is tedrynearson@gmail.com. That's the best way to get in touch with me, because I can be more immediate in terms of getting back to you. So I welcome any sort of questions, and we might know of some people in your whatever area that have questions about violent death and support groups. We're beginning to develop a list of those, but there aren't many.
So we have several more questions, so we'll share that resource. This is from Kathy, and she provides a little context in the question towards the end. So 6 years ago, she was with a close friend when she received a phone call giving her the terrible news that her college-age son's death. He was a pedestrian, and it was a hit-and-run auto accident. The driver was never identified, and the details remain scarce, other than it was a tragic event, and it was devastating. She has sat with her close friend and been with her through this experience many times, but the police were very limited in their investigation, and not too much progress has been made in the last 6 years. And so Kathy's question is, when a death by a tragic or a violent event occurs, is it helpful or even necessary to pursue answers and justice and accountability for the grieving family? And if they don't pursue that, how to support them, how to long term?
Yeah, I have some ideas about that as well. I've told you about the narratives that we're left with after a violent death, our own private narratives of the relationship with the person and the way that they died. But there is another narrative, particularly after a violent death. It's because of what I call the 3 V's: violence, violation, and volition. The dying is external, it's someone's fault, and an inquisition follows, because this has to be defined. It's so upsetting to everyone in the community that this needs to be solved. Somehow we have to come up with a motive and find a person who's responsible for this and make sure that they somehow pay. In English law, there was a system that was much more responsive to the family members, because things were established on the basis of clans. And if someone was murdered in England in the 1100s, the clans would get together, and someone from the other clan would be identified either as the murderer or someone of a similar age and gender would be killed. Or they would develop what was called blood money, where they would pay the the bereft family, to reestablish honor to this person's memory. Well, I think it was Philip II in England could no longer tolerate the high homicide rate and the money he was losing. And that's when violent dying first became a capital crime, a crime against the king. And the whole jury system developed at that point, because the narrative or the story of justice was lifted from the family and the clans. Family has absolutely nothing to say about violent dying anymore. It's all up to the police, and it's up to the courts if there's been a homicide. The suicide, when Julie died, I was handed her suicide note after the police spent about a month investigating it. And then the inquiry was private. It was up to me. I had to go through all of this in terms of guilt. But when there's a homicide or an accident, the family is forced to go through an external sort of inquiry about the dying. It's another story that has to be processed. And it can sometimes be a very misleading story. The other thing that happens in terms of the V's is there's a fourth V, which is called voyeurism. Usually one of the first community agencies that's present after a violent death is the media. And we can very much see that going on in the last 15 or 20 years with social media. And if there isn't a death that's going on in Seattle, they'll find all sorts of deaths that are going on in Los Angeles or Texas. Or big business and media recognizes that there is big money in violent death, that there's something inherently frightening, but at the same time fascinating about violent death, as long as we're distant from it. Because I think there's something counterphobic about that. We're so frightened of it happening that we need to see it in others, but not in ourselves. So that's a whole nother narrative that this family is going through, is having to process something that has very little to do with them, and it promises very little. But they're never going to be able to come up with an explanation that's going to satisfy the family, really, because the person's dead. But at least they can find justice. They can do something to honor the memory of the person. And hopefully, sorry, go ahead. This is one of the problems. Once I get started, it's hard to interrupt me.
No, Ted. So when justice isn't available, I mean, we see this now so much in the news, or so much time has lapsed. I mean, what is your recommendation for families where the pursuit of justice or holding someone accountable, where it's not necessarily there's nothing that will come of that?
Well, one of the ways of appreciating that is, if you're going to do this kind of work, is to develop a tolerance for ambiguity. You never know what's going to happen in regards to that, the family's reaction to the police and justice, until you get to know the family, and there can be tremendous variation from one family to another. And there's some family members that want to have nothing to do with any of that at all. But that's in the past, and avoidance is healthy, and don't ask me to go through any of this. It's not going to play any constructive purpose for me. And there are other people at the other end of the continuum that obsess about it. They can't stop thinking about it. I think avoidance is much healthier, really, as long as it's serving that purpose and the person is remaining stable. It shouldn't be challenged. I think that the work that we do in mentally stabilizing someone is to help them with the obsession. And that's very difficult. And if somebody has died from homicide or an accident, and we know who the perpetrator is, particularly with young kids. The reaction is get even. Getting back to what happened when clans were in charge of all of this. Eye for an eye, tooth for a tooth. I'm not going to feel better until we get that person. That's difficult to deal with.
Yeah, we have another question. So based on reestablishing the living memory prior to the violent imagery of the death for survivors, would you recommend the same process for military service personnel who have witnessed several violent deaths during deployment within their platoon? And can you speak more about this?
Well, I've worked with a number of families after there's been a combat death. I've worked with police and fire as well. One of the things that's unique about those members of those services is that sudden violent dying is inherent. It's something that's going on at a dreaded sort of level. I think not necessarily with the people that are involved directly. I'm talking about the firemen or the policemen or the person in combat. They're avoiding the possibility of dying and death. But at least when it occurs, there's something honorable about the way they've died. They died trying to protect others from death and dying, or they wouldn't put themselves in that sort of position. So there's much more of a community response after a violent death. The military does a remarkable job of sending out personnel to meet with the family right away, and they provide much more support, I think, than families with from other services. I think that the police, remember, whenever there's a policeman who's finally buried after or going through a memorial service, there'll be hundreds of police cars and motorcycles that appear to sort of lead the whole thing in terms of his or her memory. And the same thing with the fire department as well. So I think military deaths are different. They do a better job. But so they deal, I think, with the traumatic imagery, not by being open about it, but really honoring the way the person died, which is different than somebody who's not a member of that service and suddenly kills themselves or is killed in an accident or a homicide. It's something that was not anticipated. So yeah, I think in those service areas, there are other people that are sharing in the grief in an honorific way.
Mm. We have another question. Is there longitudinal research that looked into the impact of violent death of children, whether by suicide, homicide, or accident, on biological mothers and their mental and physical health within the context of a neurobiological response?
Yes. Isn't that amazing in psychiatry to have a long-term prospective study where Shirley Murphy, who is a professor of nursing at the University of Washington in the early 90s, got an NIMH grant to follow 270 mothers and fathers. And this is a community-based sample. These aren't people that are coming into the clinic. In the states of Oregon and Washington, who had lost a child who was 18 years or younger from a violent death. And she even divided them into separate groups. One group, 100 and some, went through the short-term intervention and the other group did not. So there was something controlled about the study, and followed them for 5 years. Shirley Murphy, if you want to look up her references, is a wonderful study and very comprehensive. She included lots of things that aren't included anymore in most psychiatric studies, including her work with the clergy, and because it was clergy who was most supportive initially. And mental health clinicians were down at the bottom of the list in terms of who these people went to eventually for support. One of the interesting aspects of the measures of grief and trauma, and she could only begin measuring people at around 4 months. And that's always the case after a violent death, that people are so traumatized you can't get them to come in and it's not appropriate. You can't get them to come in for study until around 4 months. But what she established was that mothers had much higher distress scores than fathers, but that within a year's time, a lot of these scores had plateaued. And they were still 3 or 4 times higher than community members who had not lost a child, that were age and matched. But what was intriguing was that at 5 years, 30% of mothers continued to be very traumatized when they were asked about the violent dying of their child. And Shirley thought that they had a post-traumatic stress disorder, and I objected to that. Or at least there's another way to look at it. I think that's something that's normative. I think a mother who loses a child to a violent death, no matter how long you're going to follow them, they are still going to be very traumatized in terms of the phantom presence of the way the person died. They get stirred up when, even with a research questionnaire. They're not disabled. They're either back at work or still functioning well as a wife and mother. There is some risk of divorce after this, higher risk. But the point is that that's important information when you're working with someone after a violent death, particularly a mother, is you're not going to get over this quickly. There is no quick off-ramp to this, and don't anticipate that necessarily. There are some people that are highly avoidant that are able to modify all of this so that they're not ruled by it in terms of it being a fixation. But it's always going to be there. There's who you were before, and there's who you are now. These two discrete sort of changes in identity that you go through. And part of your identity going forward is carrying this trauma forward with you, not getting fixated in it, but somehow prevailing over it. So it challenges the whole model of recovery. I think it's more accurate to talk about your change in identity and the prevailing, transcendent sort of goal that we have in working with people after this. You're not going to be who you were before.
Sure. Thank you. So we're going to close up. If there are any last questions, I feel like I could actually ask you a lot more questions, but I think for today, we have had a wonderful discussion, and I think it's very supportive to have your time and your expertise with us, so thank you. I have a couple more questions that just popped in, and we only have a couple more minutes, but regarding the restorative retelling group that has a 10-session time frame, when is it recommended for a survivor to join the group post-death?
I'd say starting around 6 months.
I think that's one of the things I really appreciated. I think you were one of the first clinicians, at least when I started doing this work, to hear that, you know, just sending people to therapy wasn't what people were looking for. And if people are looking for therapy, we're talking about 6 to 9 month lag, or sometimes longer. And I thought that really aligned with what I heard from people in communities and in their homes and in their faith institutions.
And that's what Shirley Murphy's prospective study has shown too, that around 12 months, the distress really plateaus. So that it really makes sense to begin intervening probably at 2 or 3 years if people aren't able to climb out of this. But the impressive part of her research was that the people who responded to her supportive group intervention, and it didn't deal with a traumatic narrative at all, which was my criticism of her intervention. But it was the fathers didn't respond to the intervention, and the avoidant mothers didn't respond to the intervention. It was the highly distressed mothers whose distress scores decreased significantly. And that was probably around half of the mothers. And after all,
go
ahead.
Sorry, Ted. No, we have a couple more last minute questions that popped in,
right.
And I just want to make sure that we have as much time for them. Could you speak to developing identity after loss?
Speak to developing identity?
Yes.
Tolerance for ambiguity. It's always different. It depends, I think, on the attachment dynamic that's going on between the person you're supporting and the person that they've lost. I also volunteered to do a lot of work in prisons, and it was sometimes very difficult. A lot of the histories of prisoners, particularly once they're off drugs and alcohol, are like something out of Dickens. I mean, I've rarely heard such trauma-filled stories. And that when their father, who had been a drug dealer and had abused sexually and physically everybody in the family, finally died when a bad drug deal went, their reaction was more of relief than grief, just because the whole level of attachment had been so distorted or absent. So that's what you have to focus on, I think, when it comes to identity, is how much of this person's identity in a positive sense is going to have to go through some sort of adaptive phase after the loss of that part. And of course, it's never totally lost. Over 60% of people at the time of bereavement are still maintaining an active conversation with the person that's died and is visited by the person that's died. I don't think that is normative for people who've been through a great deal of trauma in their family, and there hasn't been much attachment. So I think it could become misleading if we try to come up with specific sort of protocols about what ought to be inherent in any kind of intervention. You always have to improvise. And you also need to have a real vigilance for novelty of the capacity for looking at this in a different way. Children, when they lose someone violently, are processing it through their art because they don't have words necessarily to encapsulate what's happened, and neither do we. So I encourage people to actually draw out a lot of this imagery. But it all has to do with identity shifts. I am somewhat different than I used to be because of the absence of this very, very important part of me. And when someone is dismembered from me, I remember them. But it's in terms of stories, not physical sensations necessarily. So this is part of the whole identity shift that goes on, is the relationship with the person or the part of yourself that's been lost.
Right. Well, we're about to wrap up. We had a few more questions, so I will contact you offline and we'll make sure that we get those questions answered. I do have 2 closing questions. We ask everyone, if we were on a desert island and we had a community of people, we want to know, what would we find you doing naturally within the community? And what type of music would you be listening to while we were stranded?
What kind of community? Was that one of the questions?
Well, no, what would you be doing for the community? How would you contribute back to the community?
Well, believe it or not, I'm more introverted than I am extroverted. I think I'm very talkative when it comes to giving a lecture or talking about my work, but I'm pretty comfortable being by myself and being alone and vectored. So I think I would be very involved with everyone, and I'd be doing a lot of talking and listening. And it's very hard for me to not get into a role where I'm taking care of somebody. I'm very comfortable with that. That's one of the things I miss in my retirement is not being needed. So this is good for me. In terms of music,
you're needed, Ted. Yeah.
In terms of music, my favorite music is the blues. And I was telling Joelle before we met for this lecture that at one time I was a jazz guitarist. I played rhythm guitar in a Count Basie band, and the blues is my favorite kind of music. I like classical music and listen to it, and I like divine music, and I like popular music, but they all promise different levels of transcendence, from the ideal to the loving to the eternal, but the blues doesn't promise that at all. Blues promises nothing but more trouble. And that's because of where it came from, obviously, with the Black population in a very oppressed situation. But the blues contains not only a genius sort of structure of call and response and repetition and chord changes, but also with the verbal message of mastery and identity change. That I could be this sort of person where I'm blue and despairing and despondent, but no, there's a part of me that's going to pack my suitcase, go on down the line. I'm going to be all right, but I'm not going down the line being totally innocent and vulnerable. I know it's going to happen again, but I've learned enough that I can allow this to be a part of me, and I can even dance. And
you can dance, Ted. That's for the next time. Well, thank you so much for joining us today, and we'll be following up with you soon.
Good. Ted Rynearson at gmail.com. Let me know if you have any questions.
Thanks, Ted.
Yep.